Hello, and welcome to Physical Therapy Management of the Head, Neck, and Upper Thoracic region. This module will cover primarily epidemiology, anatomy, and biomechanics in order to provide a background for the clinical reasoning process that we will develop throughout this course. If you have questions about any of the material covered in this module, we will answer those questions during the live course. So stay tuned. Epidemiology. Why do we even care? Well, epidemiology can help us answer why this problem is important. It can also give us an idea of the natural history and risk factors associated with any condition, and can aid in the prognosis. Let's face it, folks, there's a lot of neck pain out there. As we can see, 70% of people will experience significant neck pain during their lifetime. This is only in a close second to low back pain. At any point in time, about 10 to 20% of the population will be experiencing neck pain, and approximately half of people have experienced some sort of significant neck pain over the last 6 months. There is evidence that the incidence of neck pain is increasing. People hypothesize that this is related to things like sitting at the computer for extended periods of time, increased stress levels, and just general lack of health. Approximately 25% of patients receiving physical therapy are coming for primary complaints of neck pain, and neck pain is more common in women than men. About 30 to 44% will develop chronic symptoms, and 37% of individuals who experience neck pain will continue to report problems for at least 12 months. There's a high rate of reoccurrence, even in those who do improve. And of interest, change scores for patients receiving placebo or control in clinical trials are consistently small and insignificant. This means that people who don't receive treatment don't get better. Hopefully, in physical therapy management, we can improve this outlook. So the clinical course. There is some good news. For example, for individuals with cervical radiculopathy, approximately 70 to 90% of patients can improve without surgery. However, whiplash disorder is another story. There's evidence that 55% of individuals who experience a whiplash injury will have residual pain and disability 17 years later. So it becomes important for us to figure out how can we best manage these individuals and especially prevent the development of chronicity. As I mentioned, treating neck pain is expensive. It is second only to low back pain in U.S. workers' compensation costs. Approximately 42% of workers will miss at least 1 week of work over the course of a year due to neck pain. And many of these workers will experience a reoccurrence. So as we've mentioned, treating neck pain is expensive. This chart highlights the cost of care of treating spinal conditions from the period of 1997 to 2005. And I've highlighted here particularly the outpatient costs, which include physical therapy, as well as the pharmacology costs over the same time frame. Outpatient costs increased 74%, while pharmacology costs increased a whopping 171%. During this time frame, there was not a significant improvement in outcomes or loss of work time, So all of this money was basically not doing us any more good. Hopefully, as we learn to manage these conditions more effectively, we not only can improve outcomes, but can also reduce costs. This is essentially what healthcare reform is all about, and I believe that we as physical therapists are well positioned to have a significant impact in controlling the rising costs of healthcare in this country, particularly in addressing spinal conditions. So regional interdependence. Dysfunction in the cervical thoracic region is related to several other regions of the body. So essentially, if you can become very good at managing conditions of the cervical thoracic region, it will improve your outcomes in other regions. There's very good evidence out there to suggest that dysfunction or impairments in the cervical thoracic region is related to temporomandibular disorders, headaches, shoulder conditions, elbow pain, and carpal tunnel syndrome. This means that essentially that song that you learned in kindergarten, the neck bone is connected to the arm bone, etc., was true. This is actually true of most of the things that we learned in kindergarten. Risk factors. Some of these are modifiable and maybe things that we can address in physical therapy practice. Important things to consider are smoking, poor psychological health, which in this case was defined as excessive worrying, depression, and general mental illness. A history of previous low back pain. This could be related to the fact that because they have pain somewhere else, they have pain elsewhere. I oftentimes also tell my patients that it's very difficult to fix the second floor if the foundation is weak. Poor sleep habits, frequent bike riding, and most obvious, previous neck pain. If you've had neck pain before, you're likely to have neck pain again. It's important to understand what people believe about neck pain because there's very good research out there that suggests that patient expectations have a great deal of influence on their outcomes. Well, unfortunately for neck pain, there's a high level of pessimism regarding recovery. Good news for us, however, is that approximately half of individuals agree that exercise and remaining active are important. Those with whiplash, however, view their condition more negatively than other neck or upper extremity conditions. Possibly via education, we can improve these expectations and therefore improve outcomes. Why so much neck pain? Well, let's talk about the anatomy and how that may influence the pain that people experience. The cervical spine is an anatomical focus of motion. Basically, the job of the neck is to orient the head and sense organs in space so you can see, hear, smell, taste things, as well as keep your balance. It is the origin of the upper extremities. Basically, it is the foundation off of which your arms have to move. It is very densely innervated. There's not only a high degree of nociceptive fibers within the cervical spine region, but also a particularly high density of proprioceptive fibers. There's a lot of fine motor control that has to happen between the neck and upper extremities. Therefore, we have lots of avenues for input into the nervous system. As you mentioned, it is an attachment site for muscles of the upper extremity, therefore applying a considerable amount of mechanical strain to the cervical and thoracic region. It is subjected to sustained and repetitive activities with daily stresses, and particularly high stresses during trauma, specifically whiplash. Let's talk about anatomy. So, in the upper cervical spine, we have some joints that are shaped considerably differently than elsewhere. We have the occiput, C1 and C2, or OAA. There's extensive ligamentous structures in this region, however there are no intervertebral discs. We have a unique shape of C1 and C2, and this unique shape directs motion in this region. C1 has no vertebral body and no spinous process. In fact, C2 has borrowed C1's vertebral body as the dens, which acts as a pivot point for C1 to move. It has a very prominent, often bifid, spinous process, which has a lot of ligamentous and muscular attachments. The occipital condyles and articular facets of the atlas slope downward immediately, and this promotes upper cervical extension, which is commonly the dysfunctional posture that we see in individuals. That forward head posture, the upper spine goes into extension, and the lower spine goes into flexion. Now, some of this may be driven by the shape of the joints. We have the suboccipital nerve that pierces through this region. There is extensive fatty tissue within the joint which provides shock absorption, and this fatty tissue is also innervated. Of significant importance in the AA or C1-2 region is the alar ligament, which helps hold the dens in place. The cruciform ligament, specifically the transverse portion of the cruciform ligament, which also holds the dens in place. And these ligaments are very important for upper cervical stability and can be injured, particularly in traumatic events. Again, we have fatty tissue that surrounds the joint to provide shock absorption. Also of unique feature in this region is the fact that the rectus capitis minor is attached to the dura. This concept has been implicated particularly in headaches, and may be one of the reasons why we will do tests such as looking at neurodynamic tests like the long sit slump when examining individuals who present with headaches. Here is your typical cervical vertebra. We have a body in the middle, which the discs sit on. You have the transverse processes with the foramen for the cervical artery. We have the space where the nerve exits at the neural foramen. We have the facet joints immediately behind that. We have the lamina and the spinous processes. Okay. You see also the joints of von Luschka, the ridges on the edge of the body, which are intended to contain the disc and guide movement as well. It's important to understand that while there are significant similarities between the cervical spine and lumbar spine, the neck is not a little low back. But importantly, the cervical disc functions very differently than the lumbar disc. Okay? The cervical disc is much less hydrated. There's a significant difference in collagen content than in the lumbar spine. It's essentially more fibrocartilage and ligament in the adult than how we typically think of the lumbar disc in the low back. As, for example, it is not a jelly donut. The vertebral end plate is oftentimes calcified in early adulthood, which has a significant impact on nutrition to the disc. By age 40, the disc nucleus is no longer mucoid in nature. It's essentially become much more dried out. There are free nerve endings in the disc, and these are both nociceptive fibers as well as mechanoreceptors. The cervical disc, the annulus fibrosus, is thick anteriorly and tapering as it approaches the uncinate processes. Laterally, the anterior fibers are arranged in an inverted V, and there is no real posterior annulus. You do have the posterior longitudinal ligament, which will contain the disc, but essentially you have these posterior lateral clefts that develop over time as we age, and this is covered by this periosteofascial tissue, essentially this connective tissue web that is embedded with fat and blood vessels. And remember, where there are blood vessels, there are nerve pathways. These clefts in the disc develop as early as 9 to 14 years of age. They may transect the entire posterior aspect of the disc in adults. So essentially you get this bipartite disc. It's essentially a gliding joint with two sections of the disc sort of sliding over each other, and this facilitates rotation. Remember, this is a normal process in the cervical spine. The uncinate joints, or the joints of von Luschka, are those little bony extensions on the side of the vertebral bodies. They attenuate shear loads with forward bend, backward bend, side bend, and rotation. They reinforce the disc. Essentially, the cervical spine, the disc is much more contained than in the lumbar spine, which means that there are less cervical disc herniations, or at least symptomatic herniations in the cervical spine. However, those joints of von Luschka can become arthritic in themselves, and degeneration, specifically osteophytic bone spurs, can encroach into the neural foramen. This may also alter the path of the vertebral artery, and is some consideration in the risk factors for cervical artery dissection. Again, we have the high degree of fatty tissue, which is highly vascularized, which means that you can get a lot of bleeding in this region during injuries. The facet joints. In the mid-cervical spine, they're at approximately a 45-degree angle in relation to the sagittal plane. Essentially, they point at your eyeballs. The facets provide about 60% of weight bearing in the cervical spine, which means more weight is on the posterior elements, whereas in the lumbar spine, much more weight bearing is in the anterior elements. The orientation of the facet joints directs motion, and very consistently in the mid-cervical spine, we have coupled motions with side bend and rotation to the same side. The greatest amount of motion is approximately at C5-6, and this is commonly where we see the greatest degrees of degeneration. As with the joints of von Luschka, degenerative changes in the facet joints can encroach on the neural foramen. Here is an image of a normal cervical spine. This is a lateral view. I put this image up because sometimes this image would be read as a straightened normal cervical spine, which sometimes is considered pathologic. It's important to remember that postures in the cervical spine, normal is highly variable. In this picture, we can see that the disc spaces are well maintained. The facet joints, we can see that 45-degree angle, and if you can imagine where the eye socket is in the skull, if you drew lines from the cervical facet joints, they would basically converge onto the eyeball. You can see in the upper cervical region where the number 1 is, that is the anterior arch of C1, and the number 3 is the dens of C2. One thing to look for is to make sure that there is not excessive space between the anterior arch and the dens of C2. Normally during radiographs we shouldn't see anything greater than approximately 3 millimeters. This is an oblique view of the cervical spine, and in this view we can appreciate the neural foramen. You see in this cervical spine the neural foramen are all very open. If you look anterior to the neural foramen, right next to the vertebral bodies, you'll see those bones come together, and that is where the joints of von Luschka are. Here's an open mouth view where we can see the dens, which is number 1, the articular pillars of C1, which is where number 3 is, and then the body of C2 itself, which is number 2. Here are some images of cervical spine degeneration. In the slide to your left, you can see that the disc spaces are narrowed. There is end plate sclerosis. There's also anterior scalloping of the vertebral bodies. This is where motion over time and pull on the anterior longitudinal ligament has created osteophytes at the edges of the vertebral bodies. On the oblique view, you can see where the joint of von Luschka has become osteophytic and has encroached into the neural foramen. Sometimes you'll see this described as a keyhole formation, so the shape of the neural foramen changes and looks like an old school keyhole. These are some CT images looking at pathology as well, where we see to the upper left a articular pillar fracture. So there's a small fragment coming off the anterior portion of the facet joint. The picture to the upper right also shows a articular pillar fracture, where you see fractures through the space where the neural foramen is, as well as in the lamina posteriorly. Below you see a Jefferson fracture. On the image to the left, there is a small fragment near the dens, which is likely an avulsion fracture of the transverse ligament. The other thing of note is that the edges of C1 look like they've slid off the articular pillars of C2. Essentially, C1 looks like it's a little wider than it's supposed to be, and that is as the arch of C1 is compromised, it essentially spreads out. The image to the lower right is an open mouth view, and you can look again to see that the edge of C1 has slid off laterally on C2. The cervical nerve roots, they exit at progressively increasing obliquity as you move inferiorly. And so what this means is that the cervical rootlets may come off of the spinal cord at one level within the spinal canal. They move down and outward in order to exit the neural foramen. This means that a disc herniation or bone spurring at one level may affect nerve roots that actually exit at a different level. There's a high incidence of interdural rootlet connections, particularly at C5, 6, and 7, and that is what the image at the bottom of the screen depicts. Again, so it's important to remember that a disc herniation that occurs at the C4-5 level may in fact affect the C5 and even C6 nerves. The disc itself is highly innervated, and this innervation arises from the sympathetic trunks, the gray rami communicans, the sinovertebral nerve, the ventral rami, and vertebral nerves. So basically you've got lots of room for innervation, lots of space, lots of potential input into the nervous system. It supplies primarily the outer annulus, but as those clefts develop, and particularly in disc degeneration, you will have fibers that start to reach into the center of the disc itself. The innervation of the facet joint arises from the medial branch of the dorsal rami, and in the cervical spine there is at the very least bi-level innervation. In other words, a single facet joint is innervated by both the nerve root that exits at that level as well as by a nerve root that exits either above and or below. In the lumbar spine there is definite evidence of innervation both above and from above and below the level of the facet joint. This innervation supplies the capsule and corresponding multifidi and semispinalis. This concept may be implicated in facet injury, where if you have injury to the facet joint, you may have nociceptive inhibition to the multifidi semispinalis. This image depicts pain referral patterns from the facet joints in the cervical spine. Essentially, these are studies where they take poor medical students, enroll them into a study so they can make some money, they get injected with an irritant, and they draw on a picture where they hurt. It's important to note the regions for each level and the fact that cervical spine facets can refer up into the head and down into the scapular region. Here are images from some similar studies done looking at disc referral patterns. So again, you take poor med student, you inject now their disc with an irritant, and they draw on the picture where things hurt. So this is C2-3 disc. Notice the pain is primarily in the posterior neck, but also radiating into the jaw. This is C4-5. Notice the radiation all the way down into the upper arms and scapular region. This is an important concept to remember because just because your patient presents with neck and arm pain doesn't necessarily mean that they have a pinched nerve. Similar concepts for C5-6. C6-7, notice the reaching all the way down to the dorsal aspect of the hand. And C7-T1, actually a much smaller region of referral. Now let's talk about neck musculature. This is not necessarily the first exercise we will give patients when working on their neck musculature, but for your higher level patients, maybe something you can consider. Here is an image of the upper trapezius. Note how the muscle spans from the base of the occiput, attached along the ligamentum nuchae, and spans out to the shoulder blade region. Also in this image, we can see where the cutaneous nerves pierce the trapezius muscle before they go to innervate more superficial structures. There are concepts as far as in myofascial restrictions that you can essentially have very, very small nerve compression where the nerve pierces the muscle and fascial layers. Here is the next layer down. We have the semispinalis capitis, splenius capitis, and levator scapula. I think it's important, while not easily viewed in this image, it's important to remember that the levator scapula doesn't go straight up and down. It moves forward at an oblique angle from the superior angle of the scapula to the cervical spine, and is very important in keeping the head from falling forward. The more forward the head is, the harder that muscle has to work. We also see here the rhomboids, the upper attachment of the rhomboids to the cervical-thoracic junction. Later we will discuss how the cervical-thoracic junction is an area that can become very easily restricted, and restrictions in this area are highly implicated in neck and shoulder conditions. Here's the next layer down of paraspinal muscles. We also see here how the posterior scalenes come down and attach to the first and second ribs. The cervical multifidi. We will be speaking about these muscles a great deal as we get to the exercise and whiplash portions of this course. They're generally considered 3 layers. Their primary job, similar in the lumbar spine, is to stabilize the cervical spine. One way to consider these is they're almost like active ligaments. They generally attach from this transverse process of one level up to the lamina and spinous process of the level above. Also in this picture we can see the suboccipital muscles, which also really do function as a deep layer. Both of these layers of muscles have a high degree of proprioceptive fibers in them, and they really help us fine-tune the position of our neck and head as we move in space. Here are the suboccipital muscles, the superior oblique attaching from C1 to the occiput, the inferior oblique attaching from the spinous process of C2 to the transverse process of C1. We have the rectus capitis major and minor attaching to the base of the skull, and trigger points in this region are oftentimes implicated with headaches. These muscles do a lot of rotation as well as upper cervical extension. And again, we have the dorsal ramus of C1 that pierces through these muscles before it goes to innervate the scalp. And tightness or restrictions in this region can be implicated in essentially a nerve compression that can cause headaches. Anteriorly, we have the sternocleidomastoid, which has 2 heads, the sternal head and the clavicular head. Oftentimes in our patients we will see this muscle working excessively because other muscles aren't doing their job. Here are some of the deeper muscles in the neck. We have both the scalenes to the side, which attach to the transverse process of the cervical spine and span down to the ribs. The brachial plexus needs to exit between the anterior and middle scalene. We also can see the deep neck flexors, which are comprised of the longus capitis and longus coli. Okay, these are those deep muscles behind your throat that are also very important in cervical spine stabilization. The longus coli, essentially single fibers cross a single segmental level, and we also have the longus capitis, which essentially crosses the upper cervical spine to the anterior portion of the occiput to control the cranial cervical flexion. Total range of motion norms. It's important for us to understand what is actually normal before we can decide is a person's range actually limited. So here are the norm values. Notice there is a bit of variation. Of note also is that you will see that left rotation is typically a little bit smaller than right rotation. These studies were done in the States, where we typically turn our head to the right as we back our car out of the driveway. Also, most of us are right-handed. So possibly we need to turn our head to the right more frequently than we do to the left. Here is depicted a patient with excessive cervical mobility and also likely some significant psychosocial factors impacting her condition. Mechanics of the upper cervical spine. There are entire courses that spend days looking at upper cervical mechanics. We will review these here, and if you have questions in class, we will certainly go over this region. Basically, the occiput to C1, the primary motion is forward bend and backward bend. And it's approximately 25 degrees of total motion, which is approximately 50% of total forward and backward bend of the cervical region. We do have approximately 5 degrees of side bend and rotation to each side at this segment. And we can apply some concepts regarding the convex-concave rules here. So during forward bend, the occiput rolls forward and glides backwards. And again, there should be a minimum of a 3 millimeter gap between the dens and the arch of the atlas during forward bend. During backward bend, the occiput rolls back and glides forward. And the arch of the atlas will basically run into the dens and may slide up a bit as the head goes backwards. In extension injuries, for example, diving into a pool, if the person goes into backward bend, as the arch of the atlas abuts the dens, it may actually fracture the dens, which is generally not good for the patient. Here are some pictures from Punjabi depicting that motion. So to the left we can see as you go into flexion how the occipital condyles slide posteriorly, and conversely in extension where the occipital condyles will slide anteriorly. Here is another image from Punjabi depicting upper cervical side bend. Here, if we view this as looking at the head from behind, as the head goes into left side bend, you will see the occipital condyles slide down and in on the left and up and out on the right. This action will tension the right alar ligament. So if you look at the space between the dens and the edge of the occipital foramen, that is greater on the right than it is on the left. We will be remembering these mechanics when we do upper cervical instability testing. between C1 and C2 is approximately 50% of the total ability for the neck to turn. In other words, it's between 40 and 46 degrees. We also have about 13 to 20 degrees of forward bend and backward bend, and a little bit of side bend at this level as well. Some people will describe that the atlas acts as a washer between the occiput and the axis. In other words, whatever direction the occiput moves in, the atlas will slide in that direction as well. So if as you bend forward, the C1 will slide forward a little bit as well. Rotation is coupled with contralateral side bend in the upper cervical spine. And it can also be coupled somewhat with backward bend as well. However, this is highly variable. This contralateral coupling of side bend and rotation allows you to keep your eyes level during rotation. In other words, we know in the mid-cervical spine that side bend and rotation are coupled to the same side. So in other words, as you turn your head to the right, your head would also side bend to the right. In order to keep your eyes level, you have to side bend to the left somewhere, and that is going to happen primarily in the upper cervical region. Also, if your patient side bends their head to a certain direction but can still look straight in front, they need to be able to rotate in the counter-rotate in order to keep their eyes facing front. In other words, with left side bend, as the ear goes down towards the left shoulder, if the nose is to face forward, the person has to be able to counter-rotate their head back front. So in the lower cervical spine, as mentioned before, side bend and rotation are coupled to the same side due to the shape of the facets. And those facet joints will down slide and up slide. So as we go into right rotation or right side bend, you're going to down slide on the right and up slide on the left. The picture to the left at the bottom here shows coupled motion with side bending to the right and rotation to the right. In the picture to the right at the bottom, you can see how the individual has kept their nose facing forward as their head has side bent. So what this means is that the mid-cervical spine has side bent and rotated to the right as they tip their head, but there was counter rotation to the left at C1, C2 in order to keep their nose facing forward. You may observe some of these deviations during your active range of motion examination, and it may start to cue you in to is the patient able to move at certain levels or not. Biomechanists will break down flexion into 3 phases. Oftentimes, as we go into flexion, it will be initiated in the mid-cervical spine, then the upper cervical region will move, and then the mid-cervical spine region will move. Again, you have a certain amount of anterior rotation and translation of each vertebral body on the one below it as the head goes forward. Similarly, in extension, you'll get motion initiated at the mid-cervical spine, then followed by motion towards the upper cervical spine, and then motion followed by more motion at the mid and lower cervical spine again. Notice in both flexion and extension, you get a lot of motion occurring at the C4, 5, 6 region. This great deal of motion over time may contribute to the high incidence of degenerative changes that we see at these levels. This chart is a summary of range segmental range of motion values in degrees from several different studies, just to give you an idea of approximately how much motion occurs at each segment. This is a similar chart looking specifically at rotation. Note again the high amount of rotation at C1, C2, and a whole lot less at levels below that. So as far as pathoanatomical features, in this case it is similar to low back pain. Oftentimes in individuals we cannot identify a specific anatomical cause. Abnormal findings are not always associated with symptoms, and in fact in the cervical spine at least 20% of individuals without symptoms will show significant pathology on imaging, and this ranges everything from degenerative joint changes to significant disc herniations and even extrusions and compression of the spinal cord that are completely asymptomatic. Degenerative changes are present in asymptomatic individuals, especially as we age, and so this is where I always tell patients I treat patients, not pictures. While imaging may provide us some information, it oftentimes should not be something that dooms the patient to some sort of poor outcome. Essentially, many of the, quote, degenerative changes seen on imaging are the radiographic equivalent of gray hair. Here's an included bibliography. I hope you enjoyed this module, and I look forward to seeing you in class.